now have a few minutes for questions from you all. There are 4 microphones that you know from the morning session. Please use one of the microphones if you have a question. Please, when you ask your question, let us know who you are and where you're from, and we'll take it away. Please, right here.
I am Jonathan Hare from WebShield and EP3 Foundation, and this is for either Don or Allison. First of all, I applaud what you're doing. You're sort of putting your data where your mouth is in terms of patient access and sort of the value of getting the data out there, and sort of creating a market for applications. Last time I checked, there was 350,000 mobile apps for healthcare, so having that, sort of the developer sandbox is great. The fly in the ointment is, you say you need to get patient authorization as the last step. But how do you know who the patient is? How do you know that's actually the patient? So last time I checked, the only thing that works at scale in terms of proofing a person is knowledge-based authentication. Asking you questions about data from like Experian or LexisNexis or Equifax. Last time I checked, you guys use Experian, is that right? Yep. So IRS has tried that. They use Equifax, which people tell me has actually more data about people in the US. And the IRS found they had a 70% success rate of fraudsters beating the knowledge-based authentication and taking people's tax transcripts because they wanted to commit tax fraud. And actually, claims fraud is actually a lot more lucrative than tax fraud. So the question is, would you consider providing or actually creating a challenge to get people inventing new ways to authenticate patients and scoring those that can be certified? Because that seems to be the weakest link. How do you know who the patient is? And do you have a program to make that happen?
It's a really important point. I'll start and then let Don talk too. But Don mentioned our interoperability and patient access rule, and it's not something that I and my team work on, but we have a great team at CMS that's thinking about these issues. And one of the requests for information that we have in that rule is around patient matching, right? So how do you actually know and link patients together, whether it's linking their data, authenticating them as an individual. So it's something that we're really thinking about and interested in kind of getting the perspective of stakeholders across the community around what are best practices in this space.
Yeah, obviously this is a major issue, and it really is a trifecta of authentication. Are you the person? Your consent to what you want to do with your data, and then authorization, which is what are you allowed to do, right? So you have to solve all 3 of these things. In the future, this is going to change, right? Because, for example, every smartphone and every browser uniquely identifies you from everybody else in the world right now, a little known fact, right? Because of the patterns of use. In the initial go-around, we're going to use the exact same authentication mechanisms in our rule as we do for portals. Now, of course, the difference between a smartphone and a portal is you have a portal for every separate provider. You go to 4 people, you have an illness that has not yet got an ICD-10 code, but it's called portalosis. Right, you have a perfusion, you want it in one spot. On the initial go-around, we're going to do the authentication by provider, right, that they know they've taken care of you. But over time, that's going to change.
Thank you. Let's go to the microphone in the back here.
Hi there, my name is Chetan Sarabu. I'm a pediatrician here at Stanford and also at a company called DocAI. Don and the team, I wanted to really thank you about articulating patient control and access to information and engagement. One group that has been really left behind in this revolution has been adolescents. Adolescent health information is very complex because every state has different laws around what an adolescent might be able to have hidden from their parents and vice versa. And so to get to the point, was wondering if you could talk about what the ONC is doing or can be doing to better support adolescent health informatics. For example, being able to separate out sensitive medications, diagnoses, so that adolescents are also properly empowered by this revolution that's happening.
Yeah, the heart of what you're hitting at is something that is called data segmentation for privacy, which is that you lock down some data in a different way than other data, right? And this is also a related issue in substance abuse. There's a law called 42 CFR Part 2 for folks who are in the substance use business. We have some provisions, again, you should comment. In fact, if folks like APIs or don't like APIs, I mean, you should definitely comment about that. The people who don't want to share the data, I assure you that they're commenting on it, and they have scads of lobbyists working to prevent you from getting it. So you should comment one way or the other. The challenge with data segmentation for privacy was really highlighted by all of the big data talks, which is all of this data is correlated. As Jeff Dean said, it may not be correlated that the human eye can see it. The retina scans and the sex would be a perfect example, right? So you can hide, let's just take that example, because we had it mentioned here at the conference. So you can hide the sex from this, you can take the sex field out, but if you have a retina scan with a 97% area under the curve on data, the data is identified, right? So the classic example is HIV, right? So you'll hide the HIV diagnosis, but if you're on, Truvada getting CD4 scores, or your GPS on your phone says you're at the HIV clinic every week, how do you, right? The data is infinitely related. So I think data segmentation for privacy is very complicated. We've done some stuff with the American Academy of, the pediatricians, Chris Lehman's group, in particular, trying to get better support for pediatrics. But you've highlighted one of the computationally increasingly harder things to do, because the better the AI machines get at doing the correlations, the harder it is to hide anything. And that's, I think, the reality of it.
Okay, we'll go here in the front.
I'm an old guy. I'm an MD, PhD at Stanford in mind, brain, and computation. It's a center here. And Don and I were contemporaries.
Wait a minute, that means I'm old. That's what we're talking about by inference.
Sorry about that.
I'm denying that inference. I'd like that redacted.
Sorry about that, Don. So I'm 72. My parents are dead. At age 66, I started collecting my Medicare checks, and as an old epidemiology healthcare guy, my feeling that I was prepared to come up here and advocate was, baby, you get your check when you're 66 years old. Your de-identified, anonymized data is ours. Let's share the data. You've had your time in the sun. You're not worried about privacy and so on. So there's that. There's that, Allison and Don. And let me back off from that stance a little bit to maybe opt out instead of opt in. And I'll leave it there.
Yeah.
So mandatory or opt out?
Yeah. I think I would say that the issue of privacy and secondary use of
for
data.
old guys, not for the 25-year-olds.
It's all relative. Let me put that out there. I think it is obviously a major national issue, right? We have so much data, so many ways to cross-identify it. Obviously, there are major business models, right? Look at Facebook, you look at Google, maybe contrast it with Apple, which is pretty aggressive in stating that they do not share the data. So the Apple Health Kit, they make the connection, but they don't actually, unless you use iCloud, get that data computationally. My sense is that ultimately this is going to be a congressional, presidential, elected person issue. It's certainly not for us as agency employees, even somebody who's, a political appointee. I think this is something where we need national consensus, and, I think everybody needs to weigh in.
I agree. I think it's, privacy and security is a really complex issue, and Don mentioned the work that's going on in the Hill. I do want to point out with CMS data, it's there's two pathways, right? So there's Blue Button, which is definitely an opt-in to whether you're using an application or you're doing research with the data. But we also do have this pathway for researchers, as long as you have an IRB approved study, to get access to the CMS data. So it's kind of there's two options, but it's always, privacy and security is always a complex issue that we're trying to thread the needle through.
It's worth pointing out to folks, and this is a subtle point, that HIPAA, so the privacy law, is actually very interesting. So we've all signed end user licensing agreement on software. I agree, right? Click to the next thing. Do you agree? Microscopic print, some contract, right? There's not a human being who's not a lawyer who's ever read one of those, as far as I can tell, right? I agree. Yeah, where's my app? Where's my data? Oh God, I got to click that thing again. HIPAA has a very different model, which is HIPAA is enumerated permitted uses, right? So in HIPAA, it's worth pointing out that it is only to be used for treatment, payment, operations, clinical data. One of the speakers this morning talked about the various privacy things. So HIPAA has a very, very different philosophy, and the enumerated use philosophy, that may be very interesting as we think about privacy, to think about it that way rather than anything you can dream up. Just throwing it out there for folks to think about.
And just to build on that, right, HIPAA does allow for research in cases where the study has been approved by
those
an
are
IRB.
IRB, right? So that's,
right. So that's one of the authorized uses in addition to treatment, payment, and operations.
Thank you. We'll go here, and then if we have time, we'll go here.
Hi, my name is Shannon Muir, and I work at the Governor's Office of Planning and Research as a science officer for, get ready for it, the California Initiative to Advance Precision Medicine. But long before I went into policy, I was an academic for a very long time, and so I'm much more familiar with the big data aspects and programs that are happening at the NIH with Anvil and Big Data to Knowledge and All of Us and similar programs. And so I'm wondering if you can talk about any integration that's going on between HHS and CMS with NIH.
Yeah, absolutely. So one of the things that we've been thinking about with Blue Button that I mentioned is how do we promote promote the use of Blue Button for research purposes, and have been talking with NIH about All of Us through a partnership we call Sync for Science, which also includes the ONC folks, about how do we, All of Us, right, is collecting all of this information to do precision medicine research, and so how do we connect Blue Button and the Medicare claims into that system? So it's an ongoing piece of work that we're collaborating on.
Yeah, we in part fund Sync for Science, which is essentially, you can think of it as sort of smartphone Fire-enabled apps to allow your data to be shared with research, and how, what are the mechanics of doing that, because that is obviously one of the interesting potentials here in terms of trials. We're also doing some work on Sync for Genes that has some similar goals.
Thank you. So we have one last question here. If you can ask it relatively quickly, it'll help us out.
Yeah, so what about, so I'm in my 30s, so let's say I had prostate cancer, so my doctor made a decision regarding surgery or any other treatment because patients decided to share the information, and there is knowledge for those patients that decided to share the information on how to treat me. But I don't want to share my information to improve treatment for others. What are your perspective for those kind of patients?
Well, that's an age-old question in economics. I think Dr. Baker can probably answer. This is the tragedy of the commons, I believe. Maybe you'll give us your perspective on that.
Actually, no, I'm going to turn it back over to the experts on this. No, obviously, data are valuable, and creating opportunities for research and respecting privacy, other kinds of issues we've been talking all about, and so trying to make sure we can take advantage of that.
I think when you look at the app, ecosystem that we're jointly trying to put together here with the White House, and what we're really about is trying to do two things: empower the American public as individuals to get better control of their care, shop for their care. But we're also trying to build new business models, new ways of thinking about the world, arbitrage out many of the, frankly, cosmically wasteful things that go on in American healthcare today. And so when you look at the data, there's going to, even you see this with privacy, there are going to be all kinds of folks trying to build brands on new products and services, we believe. I know Administrator Verma, the White House, in many discussions with Jared Kushner about this. We believe that there are going to be new business models and new enticements for people to share. That is the goal here. It was mentioned that there's several 100,000 healthcare apps out there, but today those healthcare apps are notable for the fact they actually have no medical data, right? They may have your Fitbit data, they may have your diet data, they may have pictures of you playing with a cat, whatever. That's a computer science pattern recognition joke attempt, failed. But hey, you got to try. You got to try to be out there. But there will be fundamentally new business models. We would be stunned if they're not, that will be enabled by this. And the test of each and every one of those business models is, can they engage the public, right? Are they adding value? The ones that add value are going to succeed, and the ones that don't aren't. And we think that in that world, people very much are going to want to be part of it. And we've seen this in industry after industry after industry. You look at all of finance, you look at all of entertainment, you look at all of travel, you look at any number of, verticals. They've been absolutely transformed by that smartphone, internet, IP address, RESTful JSON type of protocol. It would be really stunning if that doesn't happen in healthcare. I mean, we're sitting in Silicon Valley. I just can't imagine if Bob and I around 10 years from now, that 20 years or 30 or 40, whatever, that we're not going to see scads of that.
Well, thank you both very much. Please join me in thanking our panelists for coming.